Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observation and commentary on the JCO article, Hepatitis B Reactivation in Patients with Prior HPV Exposure Undergoing Rituximab-Containing Chemotherapy for Lymphoma, a Prospective Study, by Y.K. Sato et al. My name is Yon Arneson, and I am an instructor at Beth Israel Deaconess Medical Center, Harvard Medical School in Boston, Massachusetts. My oncologic specialty is hematologic malignancies and bone marrow transplantation. Hepatitis B reactivation is a known and potentially fatal complication of treatment with rituximab. Current strategies to mitigate this complication involve the prophylactic administration of antivirals to patients with prior exposure to hepatitis B, as indicated by the presence of an anti-core hepatitis B antibody. With this strategy, the majority of patients are able to complete rituximab therapy without hepatitis reactivation. In this prospective study, the authors seek to demonstrate the rate of hepatitis B reactivation in a cohort of patients receiving rituximab-containing treatment regimens as management for lymphoma, with the novel strategy of starting antiviral therapy only when hepatitis B reactivation is first detected by the presence of a positive viral load. Between September 2011 and September 2013, the University of Hong Kong Queen Mary Hospital recruited Chinese lymphoma patients with evidence of prior hepatitis B exposure with a positive anti-core antibody and the absence of active hepatitis B, as indicated by a negative hepatitis B surface antigen, prior to receiving rituximab-containing treatment regimens. Patients with detectable serum hepatitis B viral DNA were excluded, as were patients with other hepatic diseases or injury. Following the initiation of treatment with a rituximab-containing regimen, patients were monitored every 4 weeks for 2 years for viral reactivation by following hepatitis antibodies and viral load, and for liver injury by following liver chemistries. The primary endpoint of the study was hepatitis B reactivation as defined by the measurement of hepatitis B DNA greater than 10 international units per milliliter. Upon reactivation, patients were started on the antiviral entecavir at 0.5 milligrams daily and continued for at least 12 months following the cessation of chemotherapy. Secondary endpoints were the development of hepatitis B surface antigen and alanine aminotransferase ALT elevation at reactivation and overall survival. During the study period, 260 patients received rituximab-containing chemotherapy. 26.5% of these patients were hepatitis B surface antigen negative and hepatitis B core antibody positive. A total of 63 patients met eligibility criteria and were enrolled in the study. The cumulative rate of HBV reactivation at 6 months, 1 year, and 2 years were 22.6%, 29.3%, and 41.5% respectively. 30.2% of the 63 patients developed hepatitis B reactivation at a median of 23 months after starting a rituximab-containing regimen. 9 of those patients reactivated while receiving treatment, and another 10 following therapy. Interestingly, 3 patients reactivated more than 1 year after completing chemotherapy. At reactivation, the median hepatitis B viral DNA level was relatively low at 43 international units per ml and ranged from 14 to 920 international units per ml. Only one of the 19 patients was found to be hepatitis B surface antigen positive at reactivation and was able to clear the antigen after 3 months of entecavir therapy. No patients had an elevation in ALT detected at reactivation. A multivariate analysis demonstrated that the only factor independently associated with HBV reactivation was the presence of a detectable anti-hepatitis B surface antibody. HBV reactivation occurred in 57.1% of patients with an undetectable anti-hepatitis B surface antibody, resulting in an odds ratio of 3.51 with a confidence interval of 1.37 to 8.98. All patients with hepatitis B reactivation were able to achieve a remission with an undetectable hepatitis B viral DNA level at a median of 6 weeks of entecavir treatment. No hepatitis B-related hepatitis or liver failure were seen. This study has many important observations. First, it describes prospectively the rate of hepatitis B reactivation in a Chinese population receiving Rituximab-containing regimens for the treatment of lymphoma. At 2 years, close to half of these patients had reactivation of their hepatitis. While the majority of the reactivation happened during treatment or in the following months, several patients had reactivation a full year following therapy. The absolute rate of reactivation in this population may have been high due to the fact that vertical transmission is the most common route in Asian populations and is associated more commonly with a chronic hepatitis B infection than when the disease is contracted at an older age, as is more commonly seen in Western populations. Regardless, the high rate of reactivation observed in this study confirms the need for an effective prophylactic or monitoring strategy. Second, the authors observed that the presence of an anti-hepatitis B surface antibody was protective against reactivation. The protection was significant, with a 34% difference in the 2-year cumulative reactivation rate of HBV reactivation. Third, all patients with reactivation were able to clear the virus following treatment with antivirals, as measured by the normalization of the hepatitis B viral DNA level. More importantly, the patients were able to clear the virus without evidence of hepatic injury. The authors used these observations to suggest a management strategy where patients with a positive hepatitis B core antibody who lack the hepatitis B surface antibody should be started prophylactically on antivirals prior to initiation of therapy with rituximab-containing regimens. While patients who are positive for the protective hepatitis B surface antibody can be safely monitored with regular hepatitis B viral DNA levels, with a plan to start antiviral therapy should their virus become detectable. However, there are some limitations to the widespread adoption of this strategy. While it is encouraging that none of the 19 patients reported in detail developed any complications related to their hepatitis reactivation, it is unclear whether a larger experience would include patients who develop significant morbidity. Furthermore, the strategy of monthly monitoring of viral studies may be difficult to maintain for 2 years outside the setting of a clinical trial and may have hidden costs related to increased healthcare exposure. Given the risk for fatal hepatitis B reactivation following the administration of rituximab, it has become standard to check hepatitis serologies on all patients. Patients who are found to have had prior exposure to hepatitis B, as indicated by the presence of a hepatitis B core antibody, are started on prophylactic antiviral therapy. This study effectively demonstrates that patients with lymphoma and prior exposure to hepatitis B are at very high risk for reactivation following treatment with rituximab-containing regimens. However, given advances in hepatitis monitoring, the authors have nicely demonstrated an alternative potential strategy for managing these patients with monthly hepatitis B viral DNA monitoring and the initiation of antiviral therapy at the first detection of reactivation. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.